From the crossroad of science and human touch comes a clinician and thinker whose work explores pain's deepest complexity. Prepare yourself. Here is Professor Rolf Walter.
Good morning to everybody. Thanks a lot for the invitation and the privilege to be here standing in front of such a huge crowd with a maybe for some of you a bit of an unusual topic. So I thank Esther actually for opening the door to assessment and the variability with which we have to do probably on a daily basis in our clinical practice. I'm a Dutch physio, so I've done my physio education in the Netherlands. I was born in the Netherlands, then after 1 year of professional activity, I changed the country. I went to live in Switzerland, where I live in the Italian part of Switzerland. So I'm not a native English speaker. I've got two names. One is the last name. Walter is the last name. I'm a private practitioner, so I work on patients most of my time. And that normally means that I have to deal with a lot of variability. And the variability is not only determined by the medical diagnosis, the variability is determined by psychological aspects of the patient. It is determined by neurological, neurocognitive aspects of the patient. It is determined by hormonal aspects of the patient. By the way, did you know that estrogens protect less against pain than testosterone? And maybe that is one of the reasons why there seems to be, statistically, when we talk about pain, more female sufferance than male sufferance. And obviously, pain and the immune system is strongly involved with inflammatory processes and therefore also with pain. So that's the reason of this title, in which we have to dive a little bit deeper now. The variability means that I also have to deal with patients who don't want to have anything to do with movement. And on the other side of the spectrum, I have to deal with elite sports participants. So that's the variability which I have to deal with on a, I would say, almost daily basis. Okay, there it goes. Okay, so I don't like to call myself an expert in musculoskeletal physiotherapy. I don't even know what that means, actually. But obviously, we would like to go towards expertise in musculoskeletal physiotherapy. And obviously, that needs contemporary knowledge and understanding of what this profession is about. So I would start off with some updates on the potential complexity of pain and the individual human variability. I would like to discuss with you what are the distinctive, discriminative and decisive factors in the choice of your treatments, and what is the role of the medical diagnosis in that. I would like you to discuss with you the interactions of psycho-neuro-endocrine immune systems with musculoskeletal structures. And I would like to discuss with you what is the future of the physiotherapy profession. So, the lifetime prevalence of chronic pain may go up to 33.7%. That means that overall, 1 in 3 patients will have chronic pain. And how high do you think that percentage will be in your clinical practice? Because obviously we don't treat overall populations, we treat selected portions of populations. So the percentage of chronic pain patients in your daily practice may be much higher. And again, if we look at the risk factors, female sex, higher age, no partnership, lower education and employment. And if we look at the clinical features, medical diagnosis plays a role there, the presence of comorbidities, mental disorders and functional impairment. And obviously, that will lead to increased healthcare utilization. So we all know what acute pain is. Acute pain has a start and an end. Chronic pain obviously also has a start, but has no end. So the question here is, what is the difference? What are these distinctive, decisive factors which make someone recover from a trauma and other people have delayed or even no recovery from trauma? So this is acute pain. But what happens if acute pain episodes keep coming up within the same patient? I'm a physiotherapist since 41 years, so I keep seeing the same patients for sometimes you've made the same reasons over years sometimes. Although they massively have changed their behavior, they started to do exercise, etc., but apparently that is not necessarily enough. So what do I call a patient who has frequent episodes of acute pain? Do I call it frequent repetition of acute episodes? Or is this some kind of intermittent chronic pain? Not sure if you have seen this study. It's a very interesting study because Roger Filligan took 321 young adults, healthy young adults. So that might represent a big part of you, young, healthy adults. And he gave these young, healthy adults a standardized stimulus of 48 degrees. Now, 48 degrees is pretty hot, but it's not damaging hot. And then he looked at the responses, and what we can see is a huge variability of responses. So the responses in a spectrum of 4 on a scale to 100 to 100 on the scale of 100. So massive variation within young, healthy population. Sorry. Obviously, that means that sensory perceptual variation in the pain experience is the norm. And it also means that gender, genetics, phenotype, psychology-related characteristics interact and will determine sensory threshold. Now, this is a patient. This is not my patient. I had to do a consultation on this patient, which, by the way, is a medical doctor. So 6 years ago, this medical doctor had a ski trauma. And he had ongoing pain in his knee afterwards. Then after a year, they decided to do surgery. He had a partial lesion of the anterior cruciate ligament. So not a total lesion. So apparently after 1 year, his pain had a beginning, but had no end. Okay. His painful situation got worse after the anterior cruciate ligament surgery. So pain went up. He had several interventions, medication interventions. He probably took all the pills which are existing in the pharmaceutical world. He had done several debridements on his knee. And then after 6 years, because the pain did not stop, after 6 years, and he told me probably between 150,000 and 200,000 euro of expenses for healthcare. He went to Italy, and in Italy they decided that the only thing which could help him was a total knee replacement. Okay, so this is the picture where he had his total knee replacement. I've seen him before the total knee replacement. Okay, it was a normal knee. The knee had complete flexion, no limitation in extension, had normal rotation. The muscles seemed to be in a pretty good shape. There was no visible atrophy observable. So what do you think? What would be the odds after 6 years of continuous pain of having a positive result of total knee replacement? None. And that's exactly what I told him. But he, a medical doctor, had disproportionate faith in the medical profession, apparently, and made the knee replacement. That didn't go well, because apart from the fact that he still is in pain, he also developed an infection and had to have several surgeries and pharmacological treatments, which obviously have massive effects on your immune system and will have massive effects on your overall health parameters. How weird can it get? Where did it go wrong? How is it possible that you can only see the knee in a patient who apparently has chronic pain, chronic ongoing pain for 6 years? I can tell you, there is something massively wrong with the assessment. Sensory processing sensitivity is our personal, individual sensitivity. So we all have a certain degree of sensory processing sensitivity. It is a genetically, psychologically, and contextually influenced trait characterized by greater depth of information processing and lower sensory threshold. That means ease of overstimulation. Now, we won't have an ease of overstimulation for every sensory aspect, but we will have, some of you will have an ease of overstimulation for, by the way, your own hormones. Your own hormones. We all know at least one woman where your menstrual period is a complete disaster. You're unable to participate in normal daily activity. But the interesting thing is, we also know at least one woman where the menstrual period is no big deal. So there is, again, huge variability between humans. So this ease of overstimulation is hormonal, neurological, immunologically, and genetically and psychologically, as well as contextually determined. Nobody talks about that. We talk about nociception, and we have learned that nociception starts at the nerve ending, somewhere in the tissue. That means you have to examine the tissue. You have to examine the muscles, the joints, the capsula, the ligaments. the fascia, and within this profession, actually there are some physiotherapists who prefer to treat a single tissue treatment, the fascia. Okay, and again, how weird can it get? So we're used to think that these are all separate, neat packages of pain mechanisms. And okay, if you want to, we can also put in inflammatory pain. But again, where is the individual sensory processing sensitivity in this picture? Because obviously, your individual sensory processing sensitivity is part of the overall picture. There's a huge list on pain interactions, a massive list. I don't want to bother you with all this information. That would take me half a day. But I've just listed it up. You can look at the names. You can look it up yourself. You can read it yourself. Only a few damage-associated molecular patterns and pathology-associated molecular patterns trigger innate immune responses known to stimulate nearby nociceptors. So the nociceptor is influenced by the immune system. So nociception is not only at the nerve ending. Autonomic nervous system, peripheral nervous system, and central nervous system induce nociceptive changes. Chronic restrained stress induces nociceptive hypersensitivity. Microbiome, so your gut health, your oral health, stimulates nociceptive neurons. Inflammation induces ectopical mechanical sensitivity in the axons of nociceptors. Early life stress sensitizes nociceptive circuits. So again, nociception is not at the nerve ending. So these neat packages of pain mechanisms are really messed up. They're messed up physiologically, biochemically. That's one of the reasons why Rankamp et al. In 2025 talks about nociceptive signaling in human physiology. And he says that there is significant inter-individual variability in pain processing, related to genetic factors, sex differences, hormonal influences on nociception, sensory processing, cognitive modulation of pain, expectations, attention and distraction, psycho-emotional processing, neuroimmune interactions, impaired descending inhibition, prior pain experiences, and that in at least 30 to 40% of the population. Again, that is not the percentages you will see on a daily basis in your practice. That number is likely to be much higher. So this systematic analysis reveals that human nociceptive signaling involves complex multimodal processing from peripheral transduction to cortical integration. Now, let's have a look at a typical medical journal. The Lancet is a medical journal. Okay, so this famous medical journal already talks about nociception being pretty much complex. There is a biological dimension to pain, and there is a human psychological dimension to suffering. Another great article on the complexity of nociceptive pain is done by Robert Cockell in 2020. He calls it the distributed nociceptive system. And we're dealing with mutual reinforcing dynamics of stress and autoimmune diseases. And that not only in adults, that can happen also in very, very young people. Again, Namen Averboeg talks about biological, hormonal, psychological and social factors. Koechlin in the journal Pain talks about sensory processing sensitivity. And Van Leeuwen in the journal Pain talks about daily pain in 13-year-olds, predominantly female sex, higher body mass index, lower levels of education. Interestingly, participation in high sports levels and young adolescents with behavioral problems. So suffering can be sometimes very, very high, although there is neglectable input. And a small trauma or a spontaneous onset can bring up big, big consequences. And the medical diagnosis is only a small part of the evidence, because the medical diagnosis, especially if it's only done on MRI, CT, echography, has huge amount of false positives. Medical doctors will give different diagnostic labels to the same patient, and there is frequent diagnostic uncertainty. But we're not able to accept that because we were raised in our education that the medical doctor makes the diagnosis and that the diagnosis decides on what your treatment is. But how can the diagnosis decide on what the treatment is if the sample is extremely heterogenic? If there is variability in pain biology and physiology? If it doesn't tell me anything about the potential of the patient's recovery and the healing potential of this patient, it doesn't tell me anything about the individual tolerability and adaptability of the subject. It doesn't tell me anything about the pain phenotype. It doesn't tell me anything about the individual sensory processing sensitivity. It doesn't tell me anything about human vulnerability or the opposite, robustness. It doesn't tell me anything about psycho-neuro-endocrine-immune conditions. So this is an example, a clinical example of a young 18-year-old female. She comes to me with bilateral knee pain. And she has bilateral knee pain since 6 years. In the beginning, she was diagnosed as having a local problem. So they were looking if there would be a reason somewhere in her knee to explain her pain. The interesting thing is that she doesn't have any problem with going to the gym or playing volleyball. Her pain develops hours after. And that was for her the reason to not participate anymore, because every time she does participate, she gets pain after hours. When she was 12, she got the initial diagnosis as it must be growing pains, whatever that may mean. Whatever university taught you that, by the way, but that's another question. The MRI is normal. She was treated in several ways with medication, physiotherapy, unsuccessfully. And the final diagnosis, therefore, was it must be in her head. I don't know what went wrong here, but okay, something went wrong. Probably pushed the wrong button, sorry for that. Let's go. Okay, but she has a lot of comorbidities. She has daily headaches and neck pain. She has a lack of energy during the day, 18 years old, lack of energy, frequent tiredness, and she doesn't sleep well. She suffers low back pain. She has pelvic floor pain, although she takes oral birth control pills. She has an eating disorder. She has frequent stool problems. So, what are the odds for her in having a local diagnosis? Or if you would have to make a bet, and you have to bet, let's say 500 euros, would you put 500 euros now on a local problem, or would you put 500 euros on a systemic problem? Okay, I think this is clear for everyone. Okay, so if this would be your patient, what would be your treatment of choice? Can you see that we have several options now? Okay, there's not one option. Okay. What about having her gut microbiome examined in a thorough way? That's what we did, by the way. Okay. She did some physiotherapy sessions with my female colleague on her pelvic pain, and we had her examined by a specialized medical doctor in a specialized laboratory for her gut problems. Now, we are 1.5 years further, and she is doing well. Her knee pain is gone, her pelvic pain is gone, her daily headaches are gone. She sleeps definitely better. Circadian fluctuations. Do you see patients with good days and bad days? Or am I the only one who sees patients with good days and bad days? There are circadian rhythms in hormonal functioning, there are circadian rhythms in immune functioning. And that may explain flare-ups. That increases injury risk. And obviously that may also explain performance fluctuations. So again, health and function have strong interactions with psycho-neuro-endocrine and immune systems. Rotator cuff tear and associated risk factors, a very interesting study by Jacopo Preziosi. A smoker suffering from hypercholesteremia, diabetes and arterial hypertension has high probability of developing a rotator cuff lesion. And the event is not given by the sum of the probabilities of each condition, but each pathology interacts with each other, dramatically increasing the risk of a rotator cuff tear. So again, if you look at the end result, you make an MRI of the shoulder and you tell your patient that the only option is surgery, because that is what's happening. Those are the patients that I see on a weekly basis. Whereas there are heaps of studies which show that paced activity sessions with a physiotherapy professional are as good as. Adhesive capsulitis. Obviously, it's not just a capsular problem. It's a complex condition triggered by several systemic scenarios. And look at the amount of studies on this subject. So adhesive capsulitis is the wrong word. It's the wrong diagnosis. And the intervention should not be only locally. We are not treating the medical diagnosis only. We are treating the humans which are attached to the medical diagnosis. That does not mean, by all means, that the medical diagnosis never has any value. Obviously, I'm not saying that. But it is not determining what we have to do with our patients. So the diagnostic label often implies that the clinician knows the specific tissue pathology that is causing pain or dysfunction. That's a little bit cherry picking, apparently. Because if we have 10 patients with the same diagnosis, they may require complete different treatment modalities, have different contributing factors, and may have different goals and objectives. Or the same patient sent to several medical doctors will get different diagnoses and different treatment prescriptions, ranging from surgery to wait and see. So, what do physiotherapists do? We manage the individual. We do not manage only the diagnosis. We manage the individual. We listen, we analyze, we reason, we explain. We share our information. We plan, we measure, we monitor. We like to do graded return to function and maybe even some pain modulation. We promote patients' understanding, shared decision making, motivation, adherence. Adherence not only to the therapeutical sessions, but adherence also to the home programs, as was already mentioned by Esther before. We promote health-consistent behavior and we promote fitness levels. So the outer ring is the variability of the medical diagnosis we can get. Ranging from joint degeneration and arthritis to tendinopathy to cancer, etc., etc. But if we look at lifestyle factors, genetics, phenotypical characteristics, shift work, age, physical inactivity, environmental factors, nutrition, body mass index, sleep, and stress, they are all interacting with the medical diagnosis, with the pathologies. And they are determined by general health parameters: metabolism, mitochondrial health, thyroid health, and healthy microbiomes. Your body weight is determining. That's probably one of the reasons why female body mass index is less dramatic than male body mass index. Because what is the difference normally? Male tend to develop an apple shape, fat inside the belly, very unhealthy for metabolic reasons, and female tend to deposit their fat more around the outside, around the belly, outside of the belly, around the hips and the legs. We have biomarkers for that. So obviously that means we have to collaborate with medical doctors, because medical doctors can give us information which we are not able to gather at first hand. Again, it may be interesting to look for the link between the health of your gut microbiome and the health of your metabolic system, your energy systems. Because metabolic syndrome may actually increase injury risk. It may impair healing capacity. The inflammation of metabolic syndrome may lead to cognitive decline, to neurodegeneration. Alzheimer's disease, for example. Microbiome research in autoimmune and immune-mediated inflammatory diseases. Actually, 90% of the health of your intestines determines how much serotonin you have in your body. 50% of dopamine is made in your gut. And 30 other hormonal products. Okay, so actually, your muscles are an endocrine organ. Your fat is an endocrine organ. Your bones are an endocrine organ. So stimulating your body increases your health. It has anti-inflammatory, psycho-neuro-endocrine-immune plasticity effects. So one thing you can be sure, regular exercise is a health-promoting cure. And you can make your own slogan. Don't be a fool, get your butt off that stool. Physiotherapy is a health profession. Through lifespan, give life more years, or better said, through health span, give the years more life. And we can measure that again with biomarkers. Okay, so I go a little bit quicker. This is the summary of what we have been discussing, so I can go a little bit quicker. So it's like an individual fingerprint. We should go towards precision medicine and towards precision physiotherapy. There is no recipe. The two professionals would do very good to collaborate in the interest of the patient. And I thank you very much for your attention.